Hello, everybody, and welcome to our um, Parkinson's Awareness Month Lunch and Learn. So this is our first of two this month. So this April, we want to continue to help educate and raise awareness of the fastest growing neurological disorder in the world, which is Parkinson's disease. And we want to celebrate our Parkinson's community. So we all want to push for Parkinson's. And when we say push, we mean striding towards with forward with purpose and intention, whether it's, conquering something big or, a walk around the block, finishing a crossword, making, those new connections. It's all about giving ourselves that push. So this month and all year, we want you to get involved in whichever way is the best for you. So we're doing our sit and stand challenge. So it has begun now that we've started April, and our collective goal is to accomplish 100,000 sit and stands in April. So I think we can do it. Last year, our whole community, we did almost 90,000 across the province. So we were super close. So you can do sit stands anywhere. You can do them sitting at your kitchen table, from the living room chair, at your desk. They're very easy and important for our physical well-being. So if you don't have one yet, you can go to our website, download the tracking sheet, write down your number every day, and at the end of April, send it to us for our grand total. So we'll total them all up and then post our total at the end of April. We also have several other activities planned as well, including spring socials across Alberta all month long. You can check out our website to find a social that's close to you and register, and we really hope to see you at one of these. April 11th, as you may know, is World Parkinson's Day, and we're celebrating by turning the province blue. So many landmarks and locations all across Alberta will be lit in blue the evening of April 11th, as we join organizations all around the world to light the world blue. So our Stand Up to Parkinson's events are also around the corner here. So this coming Monday in Calgary and Friday in Edmonton, we want you to join us at one of these events where we'll be holding some fun activities, doing more sit and stands, and having some coffee and treats. All the details are on our website, or you can call us at 1-800-561-1911 to get registered. So for the webinar today, if you have any questions throughout, please submit them in the chat below. The bottom of your screen, you're going to see a little chat blurb icon. Click it and the chat will appear on the right-hand side. So after our presentations today, we'll have a little bit of time to answer questions. And as you may know, this webinar will be recorded, and all information provided in the videos by Parkinson's Association and our featured speakers is furnished strictly for educational and entertainment purposes only. So this is not meant to, be diagnostic, prescriptive, or replace the relationship, advice, and or care of your physician. So general questions about the topics today will be fielded to our lovely presenters. So today's a little unique. We've got two presentations today. So Dr. Nisa Karvich will be presenting at 12:30 on posture and mobility in Parkinson's. And first up today, we have Dr. Raissa Souza de Andrade, whose topic is collaborative AI for enhancing Parkinson's disease diagnosis. So, she graduated from Sao Paulo State University in Brazil in 2017 with a bachelor's in computer science. She also studied abroad at the University of California in San Diego and became passionate about applying computer science to improving healthcare as a trainee at the University of California. She is currently pursuing a PhD degree in biomedical engineering with a medical imaging specialization at the University of Calgary, and her primary focus is on developing distributed learning methods capable of leveraging insights from data across multiple hospitals worldwide, thus creating new opportunities for applying machine learning models to improve healthcare globally. So welcome. I'm excited to have you here today.
Thank you so much for the introduction. I actually recently finished my PhD in October, but I still work at the University of Calgary now as a postdoc. And today I will be presenting the work that I did on my PhD, as introduced well. Um, Let me just share this. Can you confirm that you can see my screen?
Yes. Yep, it's all full screen now.
Okay, great. So during my PhD, I worked to develop a collaborative artificial intelligence for enhancing Parkinson's disease. So we all had heard that many are using AI in healthcare. And the reason that this is possible and the way that this is being used is to understand how our brain or other organs are aging, to try to understand those patterns and help us to age more healthy, or to develop ways to diagnose someone earlier or faster. Also to identify where lesions are in some organs, but there are many other applications, such as survival prediction, disease progression, to correlate genetic traits with other traits in our body, and so on. And all this is only really possible nowadays because we have a lot of data that we generate in healthcare. We have the health records, we have the results of our blood work, when we have some, when the clinicians think that we have some disease, we then get some imaging data as well, such as microscopy or magnetic resonance imaging. And nowadays, we have a lot of affordable devices that we also use to track our health, such as a smartwatch. For the rest of the presentation, I will be focusing on the medical imaging, the magnetic resonance imaging, and how it's being used in Parkinson's and how I used in my work. So it's very common that when a clinician thinks that someone can have Parkinson's, it's common to request a MRI scan. And the reason for that is because with this type of imaging, the clinicians can see areas of the brain that it's perhaps with some atrophy, which can suggest that that patient has patterns of Parkinson's. The two common modalities that this machine can generate, it's called structural imaging, which shows nicely how the brain, like the structure of the brain. And then we also have the function one, which kind of show the flow in the brain. It's not as nice in terms of shape, but it's very informative as well. And then the way that these images can be used and some of the challenges that we have in terms of Parkinson's disease diagnosis is that a lot of the symptoms, they overlap with other movement disorder diseases and also with normal aging, because it's already expected that our brain will have some atrophy as we age. Another thing is that when the disease it's in the early stages, those differences in the brain can be very subtle, which can make them, the clinician, attribute those causes to other things, not Parkinson's. And then the last challenge that we have, at least in Canada, how the health system is designed, is that the family doctor and the neurologist from unspecialized clinics, which are usually the first physician that we interact with, they are not as skilled as the doctor from the movement disorder clinics. So for them to really notice those very subtle differences can take more time and be harder, which can then delay a referral for a movement disorder clinic, which would end up delaying treatment. So the whole focus of my PhD was to then use AI system and see, can we improve this diagnosis and then make this whole process faster? And the way that we vision that we could do that is, especially for those unspecialized clinics, for example. Let's say that the clinician is looking at this brain MRI and then the clinician is uncertain. Maybe it's the early stage of the disease and he does not know if it's truly Parkinson's. So that clinician needs a second opinion. And then what he can do is to ask a AI system, given this image, do you think that this patient is sick? And then this system can then say, for example, well, I think that there is 76% of a chance of this individual being sick. And here are the regions in the brain that informed my decision. If the clinician agrees, then he can do the referral to a specialized clinic, which may expedite treatment. But it's fine if the clinician disagrees. He may call another doctor or investigate further. This may delay treatment, but it's very important to highlight here that will always be the doctor that will decide what is best for the patient. The AI system is just a tool to help inform his decision. While this is very promising and it's being studied a lot in healthcare, we still have some major challenges. And the three major challenge is related with the amount of data that we have to develop these systems, how these data represent the diversity that we have in the world, and the quality of the data. Of course, a movement disorder clinic may have a better MRI scanner than those on specialized clinic, which may generate some differences in the quality of the data. So usually, if we think that in a specialized clinic and a specialized one, a movement disorder one, they want to develop this type of system, if they do it alone, we can have some problems because, for example, the age of the population that they help can be different. The number of patients versus the number of healthy individuals that they help can also differ. Usually, we would expect that we have more information about patients with Parkinson's at movement disorder clinics, while the unspecialized one usually helps more people that are healthy, which will then generate different amount of data for them to develop this type of systems. And then if they do this type of system individually, what can happen is, let's think that now a younger person is referred to a movement disorder clinic. Because the system that they developed never saw a lot of data, a lot of examples of how a younger brain looks like when they have Parkinson's, what can happen is that the system that they developed alone may fail to recognize that that one could be, that individual could be sick. And the same thing happens in the unspecialized clinic. So pretty much what happens in the end of the day is that those systems are good for the patterns that we show to the system. So if we don't show all the possibilities, or if we don't try to maximize the possibilities, they will fail in the case that they never saw. So usually what it's done to solve this problem, we would say, for example, that here at the University of Calgary, at the Foothills Hospital, we can receive the data from these two hospitals, and then we will put all this data together. And once we put this data together, we now increase the amount and the diversity. So now when we develop this system at the University of Calgary, we have a better system because it saw more examples on how this disease can manifest for different population. However, the problem with this approach is that nowadays we have a lot of data regulations that they want us to avoid this data sharing. And the reason for that is because the medical data contains information about the patient, which is sensitive, and we want to minimize the risk of leaking this information. Of course, when this type of approach are done, we anonymize all the data, try to remove all the personal information, but it can still have some breaches. And then the other reason that this approach is a little bit hard and takes a long time to really be able to then develop this type of system, it's because with all the clinics that we want to collaborate, we need to have like a lot of paperwork, we need to have ethical in place, we need to have a lot of agreements done before we are able to collect the data to then develop this type of systems. Thus, my whole PhD was to develop a approach that we avoid all this together. So the approach that I developed during my PhD, which I call the collaborative AI system for Parkinson's disease, is that instead of sharing this data across every hospital keep their data. They are responsible for keeping it private, and they are the only people that can see their data. And what we share, what we send to the hospitals to train and develop this system is the system itself. This approach we published in a journal, and then what we showed with this approach is that it addressed these data sharing issues and these administrative barriers, and it achieved the same performance as if we were able to collect all this data together and have this centralized approach. And we also showed that this approach enabled any hospital to participate, because now they don't need to really go through a lot of paperwork. So even if they are in the other side of the world, they can participate, because all we need to do is just to send the system there to train with their data. And then this approach also enabled hospitals to participate independent of the quantity of data that they have, which is very good if we think about low middle income countries. Maybe they don't have a lot of MRI data because it's quite expensive to acquire. But then if they have some, they can help us to develop this system because they can provide as little as one example, for example. Of course, this solution comes with some other obstacles. And some of the obstacle, it's actually related to the representativity itself. Because now we have this system that goes to one clinic and then we send to another one. And then what happens is that when it is in the each clinic, it will only see the data that they have there.
I'm sorry, Raissa, you're gonna
Oh,
have to
sure.
reshare your screen.
Really? Okay.
Yeah, yeah. For some reason, Nisa's just popped up.
Sorry.
No, no, there we go. You're back now.
Can you see it now?
Yeah,
Okay.
awesome.
Sorry about that.
No, no,
Did you
no
miss
problem. I'm
any?
not sure what happened.
Okay. Did you miss any slides or was in this one before?
It was just, yeah, it just turned off, so
Okay.
we're good
Sounds
now.
sounds great then. So just to recap, so we showed that collaborative AI system, we showed that it works, but of course it comes with other challenges. Because now we have this system that goes from one hospital to the other. When it is in each hospital, it just see the data that that hospital have, which means that it still see just younger population in one place versus older in another. The quantity of the data will be different as well. And also now we have other challenge, that is the machine that was used to acquire that data can be different. And we don't want this information to influence how well this this system can work. The reason that we don't want this information to influence the decision, it's because the scanner that was used to acquire the data itself should not matter. It's not a pattern of Parkinson's disease, it's just the equipment. So during my PhD, I also investigated if it was possible for this type of AI system to then use this type of information that are not relevant to the task as a proxy, as a shortcut to the task. The reason is these systems, they are very lazy. So they will find the easiest pattern that they can rely on, and then they will rely on it, even though that pattern is not relevant to the task itself. And then in these two works that I also published in these two journals, we were able to show that the MRI scans itself, it has more information than just disease. You can infer which center collected data, you can infer which scanner was used to collect that data, even though we never told the system those informations. And then we showed that this system can then exploit this information as a shortcut. To solve this problem, I then developed this technique, which we call data harmonization, that it's very similar to what I presented in the first place. The way that we develop the system, we still go from one hospital to the other, sequentially. But now what we are doing is, instead of just trying to learn how Parkinson's disease manifests in the brain, we are also learning how the scanner patterns are in that MRI scan as well. And then we force the system to forget them. So instead of doing just one task, we now do those two together. So we look for the Parkinson's manifestation on those scans. What are traits of Parkinson's disease itself? And then we look for the ones for scanner, and then we tell that system, well, forget the scanner one. I don't want you to focus on the scanner one, and I want you to focus on the disease one. With this work, we showed that we were able to then combine and integrate this data harmonization technique with the traveling model approach. And then we reduced the ability of this whole system to learn those scanner patterns by 23%, and then we improved the disease the disease classification ability by 4%. The last challenge that I investigated during my PhD was the quality of the data. So now that we have all this data and they are at the hospital that acquire the data itself, and we are not moving to a centralized place, we cannot have a human inspector to go there, look all these images and make sure that they are of good quality. So pretty much what happens is, who decide if the data is of good quality is each of those centers. But then quality itself is subjective. If they only had one type of scanner, they think and they can assess if a patient is sick or not with that scan, they will think that it's of good quality. But then when we compare with other centers, if they have a newer scanner, for example, that data could be seen as lower quality. So now that we have this problem and we cannot really visually inspect all this data, neither put all this data together, how we can then do this quality control? So the approach that I developed was similar to what I did for solving the problem of focusing on the scanner. So instead of teaching this AI system just how to identify the patterns of the disease, what we do more verification when we are teaching this system. So pretty much the way that we tackled this problem was, we were at the first hospital. We used the data that they had to teach this system how to diagnose someone with Parkinson's. After that round of teaching the system, what we do, we verify if the information that we presented to that system made the system better or worse. In other words, it means if it's helping the system to identify more cases of Parkinson's, we consider that was a good experience. It learned something new and useful. If it gets worse, which means that now I am misdiagnosing more people after using that data to teach my system, we then think that that data is not of good quality. And then we flag this data. And then later on, we verify if that's still happening. So we give it more chances to be reintroduced in the system. And if if the system is still get worse performance when you use that data, then we never use it. So pretty much we will skip that center and will not include that information when we are developing the whole system. And here I just brought some examples of the images that we were able to then identify either with poor quality because there is some shadows, some artifacts. And this case here with the arrow where this scan has some microhemorrhages, I really was surprised by this example, and it made a lot of sense when we were understanding and analyzing it, because this scan actually is from someone that is considered healthy. But for developing this AI system, it makes the performance of the whole system worse. And the reason that it does that, it's because there are some signs of this brain not being healthy. And this is a limitation that we have in most studies because usually the data that we have to develop this type of systems, the clinicians, they have their inclusion and exclusion criteria. And the way that they select uh, individuals to say they are healthy, it's by saying they never had Parkinson's disease. However, it does not mean that their brain's totally healthy. And if you include this type of information in this system and say, hey, learn these patterns as healthy, it actually generates wrong assumptions because it's not a healthy brain. So we were very happy that this approach that we developed were able to flag this situation, identify and eliminate, because clearly it's not a total healthy brain. So with this last piece of my PhD, I also show that it's possible then to have this automatic identification and elimination of data sets that can be considered low quality for the task of Parkinson's disease classification. Just to summarize then, during my PhD, I developed this traveling model and demonstrated it works for Parkinson's disease classification, which solves to some extent the problem of quantity because it enables centers with limited data to contribute, which means that we can get more collaborators. I also developed methods to understand and reduce acquisition bias in the traveling model, which was posed because now we have more representation. Having more representation, there is more variability, including the scanner variability, which should not matter for our task. So we showed that we were able to reduce the risk of biased outcome because of scanner variability. And then lastly, I developed the first decentralized data quality control method, which helps to mitigate the problem of data quality, preventing the usage of incorrect and low quality data when teaching this system to be good at classifying Parkinson's disease. Of course, there are many ways of extending everything that I did during my PhD. One example is if we already started this teaching this system and then we find a new collaborator, how we can then integrate that new center or data. If I need to send now the AI system to, let's say, Edmonton for them to train locally, but the internet is having problem, we are not able to reach them, how we deal with those situations. During my whole PhD, I just worked with the structural MRI, which is the one that shows nicely the brain. But then there is a possibility of expanding everything that I developed to incorporate more data, either images or clinical information as well. And then, of course, we have now more collaborators. Each center has their clinicians and they will have different experiences, which may pose some challenges because when they say, well, this individual we consider sick and this one we consider health, it all depends on the experience that they have. So understanding how these also impact this type of AI system, it's important. And then if there is an impact, a negative impact, implementing methodology to then minimize that impact, it's also important. I'd like to thanks a lot to the lab that was very supportive during my PhD, to everyone that always consents the use of their data for research purpose. That's the only reason that I was able to develop these methods, and to all institutions, including the Parkinson Association that funded my research. And thanks for your attention, and I'm happy to take any question.
Excellent. And that I had one here. So they were asking, forgive me, I'm not super familiar with AI, but if like the data that's being used, like is it seeing Parkinson's on the scans or is it picking, like what is it picking up that's flagging
Yeah,
people?
I see. That's an
Yeah,
excellent
because like it's they
question.
can't see it on an MRI, like Parkinson's on an MRI, so they're like, what is it flagging that?
Yeah.
Is
So basically, what happens is when we are teaching this system, we need to, the my whole project was with what we called supervised learning, which means that we have the diagnose. So I have
mm,
one scan and I have one label that a clinician gave me. And so it's paired. So I know this brain, it's from someone that was truly diagnosed by a clinician as having the disease. And if I have the healthy brain, was the clinician also that told me, well, this is an image of a healthy brain. So when we are
mm,
teaching the system, it's paired. So the system is trying to look to those images and be okay. If you are telling me that this one is a patient with Parkinson's and this other one it's a brain from an individual that is healthy, it's
mm,
trying to find how to group them apart from each other. I have a slide here that I can show that maybe helps. Um, so it's pretty much this one. I don't know if I show if it will. Okay. So pretty much what the system is trying to do is to associate what it sees on this MRI image that it's black and white. For my eyes, they do not mean anything, but it's trying to create this boundary where it will put every brain that it was said to be healthy together and every brain that was said to be sick together, and we'll try to put them apart from each other.
mm,
And that's pretty much how we teach those systems. So it's paired, we have the label the clinician gave us, and that's what it's trying to do.
mm,
Create these groups, put them apart. Because then when we have a new patient that come in and we want to see what the system thinks about, let's say that this new patient, we give it to the system and then let's say it plays it here. So what happens is if it's below this boundary, it's closer to the sick group. So the
mm,
system will say, well, there is X% of chance of being sick because it's near to the boundary. Probably will be like, oh, there is 56%, 60% of a reason for this brain from being from a sick person. But then if it plays very near to the group of the sick brains that was used, it would be more certain and be like, whoa, for this
mm,
one now, I think that there is like 90% of a chance because it's very close to this sick cluster that I
mm.
created.
So a follow-up to that one is, can the AI tell the difference between Parkinson's and then like atypical Parkinsonism slash previous called Parkinson's plus? So like MSA, PSP.
Yeah, so to
Mm,
create the systems that I developed during my PhD, I didn't have all these types of Parkinson's
mm,
discriminated. So pretty
mm,
much all of them was considered Parkinson's. So in this system here that I developed would be harder. So what would happen, let's say that if I had two types per se of Parkinson's, maybe below this boundary, I may have more than one cluster.
mm,
And then you could look and try to identify what makes a patient being part of like cluster A versus cluster B, what they have in common.
mm,
But a better way of doing this would be to teach the system from the beginning. And then instead of having just these two boundaries, then you'd have already all the boundaries that you have. And then you can teach the system from the beginning. What make it harder is that you need a lot of representation of data.
mm.
So as more class, more categories you want the system to learn, more data you need. Does it make
Awesome.
sense?
Hmm. And then last question here to kind of wrap us up. So, is there neurology clinics or hospitals here locally, like in Alberta, that are utilizing this?
Right now, what I developed, we use at the Foothills Hospital, not clinically, so it's not being
Mm,
used to truly assess new patients. We have a collaboration with doctors that are studying Parkinson's. So right now, it's everything just for research purpose to be able to develop to deploy these for the clinics. We need more. areas to work with us and probably more investment from the government, because then you also need to consider all the privacy in terms of, oh, no one will attack this system, where we will host this system, are we putting every clinic will receive a copy of the system, if we get more data, how we update this system, how we can like continually improve the system with more research data, all those things. So there is more work and more transdisciplinary work, I would say, that needs to be done to make it a product.
Hmm. Excellent. Well, thank you so much for presenting to us. This is very interesting to see where technology and health are kind of benefiting each other and getting to see this at work. And congratulations on finishing your PhD. What an accomplishment. So very exciting.
Thank you so much.